Now we're moving into chapter 35 in the 8th edition, care of the patient with cardiac problems. Now, other things all like cardiovascular diseases, MIs, those sort of things are covered in other chapters, so we're not going to go into that. With this chapter, it covers heart failure, valvular heart disease, and cardiomyopathy. So we're going to start with heart failure, also known as pump failure. The heart can't pump effectively to maintain adequate cardiac output. I'm going to go a few slides to make sure you understand cardiac output, stroke volume, preload, afterload, because once you've got that down, you can figure out the disease, the management, the symptoms. So it can be acute or chronic, mild to severe. It can be left or right or both. It often starts on the left and progresses to the right. Left-sided heart failure, which we're going to go into more, is what you can think of as a forward heart failure. There's a decreased cardiac output with reduced forward flow into the aorta, system circulation, and an increased pulmonary venous pressure, which leads to fluid accumulation in the alveoli. And I will explain that more. Right-sided failure, think of as backward heart failure, where there's a passive engorgement of the veins caused by elevated systemic venous pressure. So keep those in mind because that's going to be important. So, what is the cardiac cycle as far as the pump in the heart? We're going to start right here at the isometric ventricular contraction. In response to ventricular depolarization, which we covered in the previous chapter. So in response to the ventricular depolarization, tension in the ventricle increases. The rise in pressure within the ventricle leads to the closure of the mitral and tricuspid valves. The pulmonic and aortic valves stay closed during the entire phase. You have your ventricular contraction, which leads to your, right here, to your ventricular ejection. When the ventricular pressure exceeds the aortic and pulmonic arterial pressure, the aortic and pulmonic valves open and the ventricles eject blood. This leads to, right here, the isovolumetric relaxation. When the ventricle pressure falls below the pressure in the aorta and the pulmonary artery, the aortic and pulmonic valves close. All valves are closed during this phase. The atrial diastole occurs as the blood fills the atria. Move right on to this ventricular filling. The atrial pressure exceeds ventricular pressure, which causes the mitral and tricuspid valves to open. Blood flows passively into the ventricles. About 70% of ventricular filling takes place during this phase. And what's not listed right here is atrial systole. This is known as what I mentioned in the previous chapter, atrial kick. Atrial systole, coinciding with the late ventricular diastole, supplies the ventricles with the remaining 30% of the blood in each heartbeat, because the ventricular filling is 70%, and then the little atrial kick is that other, well, here, I guess atrial contraction, sorry, it is here. This is atrial systole, or the atrial contraction. This is 70%, this is 30%. So keep this in mind. You might come back to this. Here's your little QRST to think through the cycle of each thing happening. See here, your atrial kick is your P wave. All your contraction in your ventricle is what's happening in your QRS. During your T wave, it is relaxing and getting ready to go through the whole cycle again. So as you're thinking of your rhythms, as you're thinking when we talk about the different heart failures, and then we progress into the valves. Remember what valves are opening and closing at what phases. So if the valve doesn't close all the way, or doesn't open all the way, that it's stiff. The left ventricle loses its muscle. The left ventricle is too thick. The atrium has a problem. It's in failure. You lose the atrial kick, which is up to 30% of the cardiac output. All this is pertinent. So preload and afterload. These are two pictures I found that help bring the whole image together. The next one's going to bring it together in your cardiac output. So you need to understand your preload, your afterload, your muscle strength, how this leads to your cardiac output, which makes sense with how you are going to treat problems with preload and afterload and pump. As you can see here, preload is the blood coming in to that ventricle. Inotropy is that muscle squeeze or contraction. Afterload is coming out. So here, preload is the volume of the ventricle at the end of diastole, or the end of diastolic pressure. Afterload is resistance from the left ventricle must overcome, because it has to pump against it here. If this afterload is higher, the heart has to work harder to pump against it. So your preload here is the stretching of the muscle fibers in the ventricle. The stretching results in blood volume in the ventricles at the end of diastole. According to Starling's law, the more the heart muscle stretches during diastole, the more forcefully they contract during systole. Think of the preload as a balloon stretching as air is blown into it, and the more air being blown, the greater the stretch. Your inotropy, when we talk about inotropic drugs, that's when your balloon is stretching, or your contractility. The contractility is the inherent ability of the myocardium, the heart muscle, to contract normally. Contractility is influenced by your preload right here. The greater the stretch, the more forceful the contraction. Or the more air in the balloon, the greater the stretch, and the farther the balloon will fly when it's allowed to expel. So the more you pump in. So if something's happening and your preload is reduced, your stretch is going to reduce, your output's going to reduce. Your pressure to do that's going to reduce. Now your afterload. Your afterload is the pressure that the ventricular muscle has to generate to overcome higher pressure in the aorta to get the blood out of the heart. Resistance is the knot on the end of the balloon, which the balloon has to work against to get the air out. So just think of that balloon picture will help you. Here, we're putting together your cardiac output, so is your preload, your afterload, your contractility, and your heart rate. So your cardiac output, as your heart rate goes up, your heart rate times your stroke volume, which all of these are your stroke volume, lead to your cardiac output. One more picture to help bring it home again is your cardiac output is your heart rate times your stroke volume. Most common, I'm thinking it's like 2/3 of heart failures are, 2/3 of heart failures are left-sided heart failure. It's when the pumping efficiency failure, I called it earlier pump failure. It can be due to heart attack, hypertension, valvular disease, and the chamber doesn't empty completely at systole and diastole. This progresses into an increase in the pressure. You see here it can be the weakened muscle. It can't pump enough blood. And it backs up into the chamber or the vessel. So when it backs up up here into the atrium. So the left atrium becomes dilated. When it dilates, that increases pressure all the way back up into the pulmonary vein. That increases pressure in the pulmonary capillaries. And then this low protein fluid from your blood leaking into the pulmonary capillaries leads to fluid in the alveolar air sacs, which should sound familiar from your respiratory chapters. Heart failure, left-sided heart failure, can be systolic or diastolic. Systolic is when the heart is unable to contract effectively, such as in this weak muscle. And that's where most of the heart failure is due to systole. Some less, but some of heart failure, left-sided heart failure, or any heart failure, can be diastolic, where either it doesn't feel right or the muscle can't relax. It gets very stiff, and that'll make more sense as we move along too. So here, what does the patient look like? This is a great picture to help you remember the symptoms of left-sided heart failure. Paroxysmal nocturnal dyspnea. That's where it comes and goes. That's the kind of questions you're asking the patient. Do you get short of breath at night? How many pillows? That's a really good question. Orthopnea, over here, they can't breathe when they're laying flat. So a typical question, because they're so used to it, they don't think about it. No, I don't get short of breath at night. The key question is, how many pillows do you sleep on at night? And they might respond with 3, not even realizing that that's a problem, because it often will progress slowly. They'll go from 1 to 2 to 3 to maybe 4 pillows. Or, oh, I don't sleep in the bed, I sleep in my recliner, which means they have orthopnea. Or, do you wake up during the night and feel like you have to catch your breath? That's that nocturnal, paroxysmal nocturnal dyspnea, where it comes and it goes and it's a sudden onset. Elevated pulmonary capillary wedge pressure, which you'll only know that by having an actually invasive thing like a Swan-Ganz, something monitoring that pressure. They will have restlessness. If you think about it, they can't breathe, they're going to be anxious, less oxygen getting to the brain, causing confusion. The heart pumping like crazy to make up for decreased cardiac output, so it's going to increase the rate to try to improve output, which is actually causing the heart to work more oxygen demand, and a big vicious circle, exertional dyspnea, fatigue, cyanosis, all obvious. Pulmonary congestion, we talked about it backing up. You think of the plumbing backing up. So since the blood comes from the pulmonary circulation into the left side of the heart, if the left side of the heart's backing up, it's backing up into the lungs. So you're going to have cough, crackles, wheezes, blood-tinged sputum, and tachypnea. Blood-tinged sputum, why? Because that alveolar leakage. You're going to see with this pump failure and all these symptoms over here, hypotension, poor perfusion of the tissue, and poor oxygenation. Let's talk about the other side, right-sided heart failure. You'll hear it called cor pulmonale. And I don't remember if your text mentioned that word, but that is cor pulmonale, right-sided heart failure, which is an enlargement of the right ventricle due to high blood pressure in the lungs, usually caused by chronic lung disease. So where a left-sided failure can be this pump wall not contracting well, it could be that the muscle is getting weak because you might have this terrible high blood pressure for long periods of time, and this muscle's pumping. The muscle gets exhausted, it backs up into the lungs. Now your right-sided failure is again a plumbing problem where you have high pressures in the lungs from chronic lung disease. And that chronic pressure in those lungs causes the backup from the lungs into the right side of the heart. It dilates, stretches, there's an overgrowth of the cells resulting in hypertrophy, this time on the right side rather than the left side of the heart, because the right ventricle fails as an effective pump and cannot eject blood that's returning from the vena cava. The blood backs up, so the blood is coming from the vena cava into the right side of the heart, but the right side of the heart can't do it. So again, you have a backup. The backup goes out back into the systemic circulation. It can be because of this left failure that backs things up, causes pressure in the lungs, which backs things up and causes pressure in the right side of the heart, which backs things up and causes systemic circulation problems. It can be pulmonary or tricuspid valve problems, some kind of congenital heart disease, cardiac arterial disease. It could be an MI, a heart attack, myocardial infarction that affects the right side of the heart. But again, when you're thinking of heart failures, we talk about valves, think of the pulmonary and tricuspid valves affecting the right side of the heart. I just noticed, I'm going to back up. I just noticed that I somehow inadvertently hit the pause button and did not resume, so I'm not sure at what point it stopped recording. Sorry if I repeat myself. Just back up here to the right-sided failure, cor pulmonale, the backup, and again I apologize if I repeated myself. So the backup to the right, often secondary to chronic pulmonary problems, you're going to back up into the system. So the blood is backing up, so you're going to have enlargement in the abdomen into the spleen and the liver, which starts to leak out, just like the lungs leak. This liver and spleen are leaking, and you end up with ascites because you have this increase in the portal pressures. The whole periphery has an increased pressure, so you can have dependent edema. You're going to have distended jugular veins. You're going to have GI issues because of that pressure buildup. You're going to have weight gain. Of course, you're going to be fatigued. And then this picture, and again, I'm sorry if I'm repeating myself, this is just a good picture to have. It kind of summarizes right, left, what's going on, what it looks like. I'm not going to go over this whole slide. It is there. It's in your PowerPoint presentation. You can look at it, you can print it, you can take notes on it. Okay, so evaluation and management of heart failure. I'm going to kind of take this as a whole. I went ahead and put this picture in here again on the preload and afterload, because it gives you good points here that your preload is increased in hypervolemia, that's excessive volume, regurgitation of the heart valves, and heart failure. Your afterload, which is resistance the left ventricle must overcome, your afterload is increased in hypertension and vasoconstriction. Remember, your increased afterload results in increased cardiac workload. So there's labs and diagnostic tests, different medications, and some other kind of therapies. So what do you think the labs would be? If you think about what you're doing, you need to check for your oxygenation. So you're going to do blood gases. In heart failure, they usually start with a mild respiratory alkalosis. Your PO2 is going to be low. You're initially retaining. Blowing off. You're blowing off too much of your CO2 because you're the gasping, and then as it goes on, it becomes a respiratory acidosis where you lose that exchange and you're retaining your CO2. Some serum blood tests. Your text does a good job talking about your BNP P or beta type natriuretic peptide. I could never say that word, it always just BNP. Make sure you're clear that it's this natriuretic peptide, that you're not being mistaken or hearing BMP, which is a basic metabolic panel, because this is not a panel, it's a specific peptide that's increasing heart failure, and they use it to monitor the severity of the heart failure. If a BMP is greater than 100, it predicts heart failure and a 1-year mortality. They have come up with all kinds of devices to prolong that. We used to say cardiac output of less than 30 was significant, because you want it to be like 60, and a cardiac output of 20 was what we called a cardiac cripple. But as we get into some of these meds, and especially the devices that are helping people quite a bit in their quality and length of life. What else do you think you're going to check? Well, you want to look at your electrolytes. Sodium, potassium, magnesium, calcium is significant with heart muscle contraction, and your BU and creatinine because you're looking at your kidney function. You're looking at a urinalysis because you're looking for microalbumin, which is the small particles of protein that leak through because the kidney is starting to be damaged or struggle because of this overload of fluid. You're looking at your liver enzymes. Remember, with right-sided failure, how you have increased portal pressure, and it's going to affect your liver and your spleen, leading to ascites. So you are looking at your liver function. The labs for your liver function that you're looking at are your ALT and your AST, for looking for end organ damage or involvement from liver congestion. Another is your bleeding and clotting times. Again, because remember, your liver and spleen are involved here, so you're looking at your clotting times. ESR, or your erythrocyte sedimentation rate. Why are you looking at that? Because it is elevated when there's an inflammatory reaction caused by heart failure. Many things, ESR or SAD rate is considered a very non-specific, but it's called an inflammatory marker. It tells you this inflammation somewhere. Multiple things can elevate it, but that's one of the things you're going to look at. You have a PT and a PTT. A PT is your pro time, and you're going to get it with your INR, which is your ratio. And that is monitoring when you're giving them Coumadin. Your PTT, or partial prothrombin time, is what you're monitoring your levels when you're on a heparin therapy. You're also monitoring your platelets. Where are you going to find your platelets? Your platelets are part of your CBC, or complete blood count. PT, PTT are other specific tests. Your SED rate may or may not be part of your CBC. ALT and AST, your liver enzymes, are only if you're getting a complete panel. If you're just getting a basic panel, that's not going to be on there. Magnesium has to be quartered separately. Albumin, you're checking your albumin again for your liver congestion. Your albumin levels will be on your complete metabolic panel. Transferrin is part of, I think it has to be ordered separately, or it might be in your CBC. You'll have to add it on if you're doing a differential and ask for specific transferrin, because that's telling you about your iron stores and it tells you a lot about what's going on with your spleen. What are some diagnostic tests? We get here into diagnostic tests. Those are your chest x-ray, because it can show you that heart is enlarged. It can show left ventricular hypertrophy, or an enlargement of the left ventricle. A significant test is your echocardiogram, 2D echo or Doppler ultrasound, where it looks at the left ventricular size. It watches the valves open and close. You see wall thickness, and it will give you an estimate of your ejection fraction. Hopefully all of you will have an opportunity, at least I know at Hillside, to get through radiology department, have a rotation through there where you can see an echo actually take place, and it'll help you, it'll make a lot more sense. So an EF of less ejection fraction of less than 50%, that's looking at your cardiac output, indicates your systolic dysfunction. Another echo can be a transesophageal echo, where they'll do conscious sedation. They just put them on usually a nasal cannula. They go down the esophagus and they look through the wall of the esophagus, transesophageal, and they can see the heart valves, the heart function that way. It's interesting if you get to see one. Of course, your electrocardiogram or ECG, because you're looking for underlying causes, ischemia, MI, is there a valve issue, is there a block? A stress test, they can do it where it's an exercise stress to raise the heart rate and blood pressure. Some people cannot do the exercise, so they do it with chemicals. I'm used to the dopamine stress, there's persantin stress, and I can't think of now, there's another drug they're using for them. Cardiac angiogram, what we know as a cardiac cath, where they're going to go in, usually through the groin, and they're going to check the coronary arteries. They can also do pressure, evaluate the pressures in the ventricles, your wedge pressure, all your pressures in the right and left, to go over that. So the next couple of slides, we're going to go into the medications, and then we're going to go into some other type of therapies, including surgical. So this was, I thought, a good slide to help you with the medications. Your beta blockers, it has the website on it if you want to go in there, showing you exactly where the beta blockers work, why you would give digoxin and inotropes for increasing that pump, your ACE inhibitors, your diuretics. So this is just an excellent slide. So of course we have to think of oxygen. You need an order. Think of it as a medication, because you're going to increase the available oxygen, that because the heart is pumping more, using more oxygen, leading to ischemia. So you want to definitely give them oxygen. Some things to decrease your preload and afterload to decrease the work of the heart are some loop diuretics such as furosemide, or another your text talks about very well is your Bumex or Bumethadine. I have done that when you do it in a continuous IV infusion. In this type of situation, I've seen Bumethadine used more than a furosemide. I don't know that I've given a furosemide drip or Lasix strip, but I have used the Bumex. Hydrochlorothiazide is a milder diuretic, not used that often for this type of situation because it doesn't have a long effect. Zeroxylin, which works in different part of the loops, is really good because of its long acting. It lasts for several days. Some other drugs. Forgot with your loop diuretics, of course, you're watching for hypokalemia or low potassium because they are not potassium sparing. So you're losing potassium with it. And whenever there's exchange of fluids, you're watching your sodium. You want to restrict your sodium and your fluids because of fluid retention. You're reducing that preload so the blood returns to the heart with less effort. ACE inhibitors, which are mentioned here. There's ACE inhibitors and ARBs, or angiotensin-retensin blockers, or aldosterone antagonizers. So ACE inhibitors, think of the prils, such as lisinopril, quinapril. It's usually the first line of therapy to control heart failure. Their action is to decrease the ventricular filling pressure and the systemic vascular resistance by lowering the blood pressure, and then that results in an increased cardiac output. ARBs, or angiotensin-retensin blockers, that end in sartan, such as losartan, valsartan. Those drugs also have the same effect. You'll see vasodilators such as the nitrates, nitroglycerin drip, hydralazine, let me think. Oh, and your like prazosin or Minipress is the brand name, but prazosin. So if you mention, I think it was on the previous chapter when I mentioned the zosins, which are alpha receptor blockers, back to your autonomic nervous system, your systemic response, your fight or flight response that increases heart rate, increases pressure, squeezes things down. So if you block that alpha response to decrease that resistance, which results in a vasodilation, you're dilating to increase the cardiac and renal output, reduce the circulating volume, the preload and the afterload. Your beta-adrenergic blockers are what we call beta blockers. Remember your alols, like your metoprolol, bisoprolol. They block, again, the effects of the epinephrine on, there we go, on the sympathetic side, the fight or flight side, your adrenergic response. It blocks those beta, and remember, there's beta 1 and beta 2, beta 1 being heart, beta 2 being lungs. So whenever you're using these, metoprolol is one of the ones I believe is selective to the beta 1, so it doesn't cause as much of the bronchoconstriction that non-selective ones such as like atenolol would do. Okay, so inotropic agents. These are ones, I don't know if they're on your picture. Here we go. Inotropes like digoxin. Brand name Lanoxin, but know it as digoxin because that is the generic name. They used to use it all the time, but it's not as common as it used to. We have other inotropes. Digoxin is one of those meds that have what they call a small or narrow therapeutic index, meaning it works within a very small range and it doesn't take much to become toxic. And toxic leads to all the heart blocks, rhythm issues that we saw in the previous chapter. So as your text tells you, let me see here, this is on page 686, it talks about digoxin, how it's been used, and then mesoteride or Natricor, that's the name I know it by, is the Natricor, as an inotropic medicine to increase that squeeze. Dobutamine is one that you will see quite often. It's an beta-adrenergic agonist, so again it is working against the adrenergic response from the beta receptors in the sympathetic nervous system. Milrinone, that you will usually use in a really severe patient to increase that contract the function and squeeze of the heart. I'm looking at some of these others. I think I discussed those already that are in there. What's another thing you need to do? Well, they're going to be anxious, so a lot of times they will have lorazepam to help decrease the anxiety, and that helps them rest, which decreases their cardiac workload. I think I mentioned anticoagulants such as heparin, warfarin. I think I said Coumadin. I apologize. Warfarin is the generic, so know it by warfarin. There are Plavix, which decrease generic. Generic for Plavix, clopidogrel. I think of it as making the platelets kind of slippery. You don't want them to end up with a clot because, again, they're not pumping well. Blood is pooling If you remember from the previous chapter, the risks of going into atrial fib and atrial flutter are very high. You're going to give IV fluids, but you're also very, very strict I&O, restricting intake of all kind. You're going to avoid saline solutions like 0.9% saline because you want to decrease their sodium, which is causing retention. You're monitoring their electrolytes, especially the potassium, replacing when necessary. Let's see, let's go into the next slide. This is talking about other interventions. This here is an IABP, or intra-aortic balloon pump, and I'm trying to find it in your text because it talks about a more permanent. I don't know if I just missed it, but I didn't see it here. And this is a temporary, an IABP, or intra-aortic balloon pump. It goes into the femoral. I liked this picture because it shows how it goes up and it does the pump. This is the machine that sits at the foot of the bed. There was a time when the critical care nurse did the sole thing, managing that. Now respiratory therapy is very involved in it. Between the two, it's noisy, it's pumping. This is a temporary device to get them through the worst of the failure or get them into surgery for or some kind of intervention for more permanent management. Okay, over here, sort of more permanent, is a device, a VAD, or a ventricular assist device. I'm used to calling it a VAD, V-A-D. This just gives you a kind of picture of this implant. Usually that is something they do when somebody is waiting for actually a heart transplant, but it's called a VAD. Then this picture here is your ACORN cardiac support. No, I'm wrong. Sorry. This one is the cardiac resynchronization therapy, or biventricular pacing. And as we mentioned pacemaker in the previous, that's what it is pacing leads in the atrium and the ventricle to regulate, stimulate, keep the rhythm going, hopefully help that impulse go through and help with contraction. There are some mentions in your text on gene therapy. I'm not going to go into that, and some other devices. And then interesting right here is a myosplint, or an ACORN cardiac support device. A myosplint is one type of them, and I had not actually seen these used, but it's interesting, and it's exactly like it describes it in your text as a mesh jacket that's placed over the ventricle, provides support and avoid overstretching of the myocardium muscle. And this is to try to help improve that ejection fraction for that muscle that is stretched out, weak, and not able to pump. I guess I had on pause again and I didn't realize it. This is a really going into the valvular heart disease. I gotta watch that darn pause button. Okay. So this picture shows you what valves are involved with diastole, what valves are involved with systole. So, and stenosis, where the valve doesn't open all the way and not enough blood passes through. Where regurgitation, the valve doesn't close all the way, so blood leaks backward. So when you're looking at them, you can figure out what's happening in the heart, which side of the heart, to lead yourself through what would that look like in the body. What kind of signs am I looking for? Some patients can have both a stenosis and insufficiency or incompetent where it doesn't close all the way. If they have a valve disease, it leads to increased work for the heart muscle. And again, increased work of the heart muscle or poor functioning muscle leads to more pressure on the valve, so it's a back and forth thing. It can be acquired valve disease from problems such as an infection, like an infective endocarditis, rheumatic fever, which your text mentions, the rheumatic heart valve disease. It can be change in the valve structure, such as stretching or tearing of the muscles. That can happen from degeneration or also from dilatation of the pressures in the heart. It can be congenital valve disease that happens before birth. The valve, often with congenital, is an abnormal size, or the leaflets don't form right, or they're abnormally attached to each other. These congenital are more common in the aortic and pulmonic valves. So with your valve, your text covers pretty clearly on mitral and aortic. It doesn't go into the pulmonic or the tricuspid. And so mitral stenosis, which leads to pulmonary congestion, right-sided heart failure, which occurs first. So a lot of times you want to fix the valve problem before it causes the heart failure. They're usually, with mild, they are usually asymptomatic. As it progresses, they get dyspnea on exertion, orthopnea, paroxysmal nocturnal dyspnea, hemoptysis. Does this sound familiar? Pulmonary hypertension, because the mitral valve is on the left side of the heart. So if it's stenotic and the blood can't get through, think of the backup, all the symptoms that you would see with left-sided heart failure. So think of it that way. And the primary cause of, then we have mitral regurgitation, where it is insufficient or incompetent. And during diastole, regurgent output flows from the left atrium to left ventricle, along with normal blood flow that leads to an increased volume that has to be ejected because it's regurgitating and causing an increased volume. The primary cause for mitral regurgitation are degeneration and due to aging, because it's more common in above age 65, I think even above age 70, and also infective endocarditis, which we will touch on that. Usually progresses slowly, and it leads more to a right-sided heart failure. Mitral valve prolapse, multiple causes for it, most patients asymptomatic. Dizziness and syncope, palpitations can because of atrial and ventricular dysrhythmias. Your text goes into aortic stenosis and insufficiency. Just kind of read through and be familiar. So what are you as a nurse need to do? As far as medications, there's not like a specific medicine just for this. You're going to treat the effects. So you have your diuretics, your beta blockers, digoxin for that inotropic, giving them oxygen. You're treating the symptoms of the heart failure. And as it's progressing, you're watching your cardiac output, you're watching your rhythm, you're treating rhythm issues, and the thing is to repair that valve. So how do they repair? They have some non-invasive management, like right here, where there's a balloon valvuloplasty. Your text does a good job talking about it. Says it's in, I guess it is invasive, but not where it's not like an open heart surgery. It's non-surgical. It's invasive but non-surgical, so instead of putting non-invasive, I should have said non-surgical because it is invasive. I apologize. It may be the initial treatment choice for people with a non-calcified mobile mitral valve. A physician passes a balloon catheter from the femoral vein through the atrial septum to the mitral valve. The balloon is inflated to enlarge the mitral orifice. They can also use this for an aortic valvuloplasty. And it is, another is the interesting little picture over here, which is a minimally invasive technique called the transcatheter aortic valve replacement. Then here is a surgical procedure, but they are making these minimally invasive where they're not, where the opening just part. That's the only picture I could find that actually showed getting in there where they do a direct or open reconstruction, angioplasty, or heart valve replacement in there. So this they can reconstruct, or they may change out the whole valve. So I'm going to move on from here. Endocarditis. So the next section in your talks about infective endocarditis. I thought this was just a great picture. An infection of the innermost layers of the heart. It may occur in people with congenital valvular diseases and those who have had rheumatic fever. Another risk factor is IV drug users, where they could develop endocarditis. And interestingly, I saw an endocarditis once on somebody who had had a tongue piercing, and it caused the infection to go straight to the heart valve, resulting in endocarditis. It got so significant he ended up with a valve replacement. He was in his 20s. Several months after the valve replacement, came back in and actually had an infection from the valve replacement, and he died. But of course that was probably in the early 90s, and we've come much further with things now. But remember, your mouth is very, very vascular. So oral cavity, there's now in your Healthy People 2020, there's a whole big thing about dental care, assessing the mouth, for nurses to be assessing and looking, because the mouth is so incredibly vascular. It is an incredible route to endocarditis, infection going right to the heart valve and resulting in here what is often referred to as vegetation. If you can see, that's what it should look like, and you see this vegetation or growth of bacteria on that valve. You have a chart, it's 35.8, that talks about infective endocarditis, that you're looking for fever, night sweats, fatigue, anorexia, weight loss, a new murmur or a worsening of an existing cardiac murmur, signs of heart failure because the valve is failing. You might have systemic embolization. If you think of this vegetation here, sometimes that vegetation can break off and become a moving emboli. Petechiae, which you should remember from studying on pulmonary embolus, seeing petechiae or splinter hemorrhages. And of course, you will have positive blood cultures with endocarditis because there's an infection that is in the systemic circulation. So you will have positive blood cultures. And heart failure is the most common complication of infective endocarditis. You're looking for right-sided or left-sided failure, and we've already covered very well over all of those. Embolization is a major complication. It can throw a clot to your spleen, causing splenic infarction, which is very, very painful. They throw a clot to the head. You're looking for neurological changes. You're looking for signs of a PE with pleuria, chest pain, dyspnea, cough. I mentioned petechiae. So what are your tests that you're going to do? The blood cultures. We talked about murmur, an echocardiogram, a TEE, transesophageal echo. Of course, drug therapy is antibiotics, very, very, very long in the hospital, beginning with IV antibiotics and then following with oral antibiotics for up to a couple of months. The anticoagulants aren't going to prevent an emboli because, again, this is not a clot, it's a vegetation that is breaking off. So giving them an anticoagulant is not going to help. Surgical management is going in and replacing that valve. They talked in the text about sterilization of the valve. I've not seen that. That's something fairly new, but it is mentioned here. I did not put any slides here on pericarditis. It's an inflammation in the pericardium, the sac around the heart. It can happen after an MI. It can happen after a severe infection, usually in the respiratory system, that leads to becoming systemic and infecting the outside of the heart. You will hear a pleuritic rub with that, which instead of hearing a rub going with your heart sounds, you hear it with your pericarditis. Instead of hearing it with your lung sounds, you're going to hear it with your heart sounds. It's a pericardial friction rub. You're going to have an elevated white blood count, and usually you're going to have a fever. You want to manage the pain with things that take inflammation down, non-steroidal anti-inflammatory drugs, the ibuprofens, Toradol. They can use corticosteroids, but only if there is not an infection involved, if it's just a pericarditis, not infection. Interestingly, colchicine, which I'm used to using colchicine in like a gout, that can be used to prevent pericarditis reoccurrence, and I found that fact interesting. I'm not going to go into cardiac tamponade very much, just understanding that cardiac tamponade is an emergency. You do have that widening pulse pressure where your systolic's going up, your diastolic's going down. You will hear pericardial friction rub with it. It is an emergency that needs to be acted upon immediately. And then your text goes into rheumatic carditis, which just read over that. Be familiar with it. I mentioned it briefly. We covered a little of that in pediatrics. So I'm going to go to the last section. Cardiomyopathy. I thought this was a perfect picture in helping you understand cardiomyopathy. When you hear the word cardiomyopathy, they are referring to a disease of the heart muscle fibers. So it can be dilated, hypertrophic, or restrictive. So the hypertrophic can be obstructive and non-obstructive, and restrictive, which is very, very rare of the three. It's the second most common direct cause of sudden death. Coronary artery disease is number one. Cardiomyopathy is number two. Dilated, right here, dilated cardiomyopathy usually isn't diagnosed until it's in advanced stages, and then prognosis is very poor. Some other complications of cardiomyopathy are heart failure, arrhythmias, hypoxia, pulmonary edema, valvular dysfunction, hepatomegaly, multi-organ dysfunction, all resulting from the low cardiac output. So you can put this together now. If you think of the whole function, that's why cardiomyopathy is put at the end, because everything we've learned will help you understand this. So risk factors are previous myocardial infarction, hypertension. It can occur with pregnancy, viral infections, genetic predisposition, a birth defect, some kind of cancer, chemotherapy drugs, and alcohol use. Males and blacks of both sexes are at greater risk. Although this one here, restrictive cardiomyopathy, is very rare, it can be caused by autoimmune diseases such as sarcoidosis, chemotherapy, chest exposure to radiation for cancer therapy, and hemochromatosis, which is an excess of iron in the blood. Most people with cardiomyopathy have idiopathic or primary, but some are secondary due to causes that I just discussed. Dilated, right here, cardiomyopathy primarily affects, you see here, systolic function. It results from extensive damage of myocardial muscle fibers. Consequently, contractility of the left ventricle decreases. So you see here the dilated is the most common. Behind it comes the hypertrophic, and the least common over here is restrictive. So this dilated is enlargement of all cardiac chambers, and it's a systolic dysfunction. And if you don't remember the systolic, go back to the earlier in the beginning of this lecture or the PowerPoints talking about systolic function. It is like a chain of events. So when systolic function decreases, stroke volume, ejection fraction, cardiac output decrease. So as end diastolic volume increases, there's pulmonary congestion, and I'm not going to talk you back through the whole thing. So the kidneys now are stimulated to retain sodium water to try to maintain a strong cardiac output, and it also causes vasoconstriction as the renin-angiotensin system is stimulated. So this is your body trying to compensate, but these compensatory mechanisms aren't enough and the heart begins to fail. As the left ventricle dilates, their venous return and systemic vascular resistance increases, the atrium starts to dilate, the ventricles dilate, blood is pooling, and all those other problems happen, and then you start to have a mitral valve dysfunction, which just aggravates it more. When we get into here on the hypertrophic cardiomyopathy, it's a diastolic dysfunction, risk of sudden death in young athletes, a thickened left ventricular wall. Major features are asymmetrical left ventricular hypertrophy. One side of the wall versus the other. It's not rounded through the whole ventricular wall, left ventricular wall. There is hypertrophy of the interventricular septum. There is rapid, forceful contraction of the left ventricle, and that left ventricle is not able to relax, and it's causing an obstruction of the left ventricular outflow going out. The hypertrophied ventricle becomes stiff, non-compliant, unable to relax during ventricular filling, and so the filling is reduced. The left ventricular filling pressure rises, increased left atrial pulmonary venous pressure, and venous congestion and dyspnea, and take you right back through the whole circle. Again, this muscles hypertrophy in the left ventricle will lead to a mitral insufficiency and additional problems. What are you looking for? On the dilated cardiomyopathy, you're looking for shortness of breath, orthopnea, dyspnea, peripheral edema, hepatomegaly, everything murmurs. So you're looking for valvular problems, heart failure issues, the whole thing that we've covered. On your hypertrophic, you're looking, because this is a high cause of sudden cardiac death, angina, dyspnea, fatigue, and irregular pulse rate, atrial fibrillation. On restrictive, the least common one, they have signs of heart failure and fatigue, dyspnea, orthopnea, chest pain, edema, a gallop. You're going to be doing to evaluate, test for these, echocardiogram, chest x-ray, cardiac catheterization. Sometimes they'll do a heart muscle biopsy. How is it treated? Non-surgically, they can do medications and certain devices, and then the surgical is actually looking at a transplant. So medications, ACE inhibitors again are the first line. Remember, your ACEs are your pills to reduce afterload through vasodilation. If you think of your left-sided heart failure, it's the same treatment. ACE inhibitors, diuretics, the digoxin are things for the inotropic pull, beta-adrenergic blockers, your angiotensin II receptor blockers or ARBs. Here you're going to have some calcium channel blockers to reduce the blood pressure and the afterload. They will use antiarrhythmics such as amiodarone. They may do cardioversion if they're in atrial fib to get them back to a rhythm. You may put in a pacemaker. They may have the biventricular pacemaker inserted. Anticoagulants, again, if they're in atrial fib, the risk of emboli. They may have to do a CABG for revascularization, coronary bypass graft. They may have to repair or replace a valve. Lifestyle modifications, smoking cessation, low fat, low sodium, trying to get them more physically active as they can tolerate, and avoid alcohol. They can put in left ventricular assist device and the VAD. Hypertrophic, the beta-adrenergics, the ARBs, the antiarrhythmics, pretty much the same thing you're seeing on the others. I'm not going to go in these more because I think I've covered the heart failure, the pump, the meds, the drugs, and I don't want to go to the point where I'm confusing anyone. And of course the heart transplant is also mentioned briefly in your text. So I thought I'd end again on a little humor. I thought this was really cute. Dave dropped out. He had chest pains and trouble breathing. They think he may have competitive heart failure. So I hope this lecture was helpful. Hopefully you read your text before you listen to it, and then can go back in your text or have your text open while you're listening to it. You can print off the PowerPoint itself and take notes on it as you're listening and reading through your text. Okay, that is the end of my review of Chapter 35.